this is a randomized phase 3 trial of aumolertinib versus gefitinib as a first-line treatment with locally advanced non-small cell lung cancer who are exhibiting EGFR 19 del mutation or L858R mutation. So this is a very interesting paper because, when we think of some another molecule in an EGFR mutated patient, what information that will help us improve our treatment. So we are dealing with exon 19 del, we are dealing with exon 20 insertion and exon 21 substitution. That is a bad disease, what we call it a L858R, and also some uncommon EGFR mutations. So for exon 19, we know that historically this subgroup has achieved a better outcome than L858R. And again, we have understanding that second and third generation TKIs have shown a substantially better progression-free survival as compared to the first line. Now talking about exon 20, this is basically refractory to TKIs and we are still struggling to have a newer molecule which can act upon that. Talking about L858R, we know it is a bad disease and the maximum use of drug that we have has given a maximum PFS of not more than 14.4 months. And talking about uncommon mutations, though the number documented is perhaps much less than we talk about, and perhaps we can have a larger number of patients who have uncommon mutations and only the drug afatinib, which has shown some substantial response on treatment. So with this background, I start with my presentation. We're talking about aumolertinib, which is a new novel irreversible EGFR TKI, and that has shown sensitizing action both against the sensitizing and the resistant mutations of EGFR. So aumolertinib has been approved in China for treatment of patients with EGFR mutation with T790 mutation upon progression of disease on the first line TKI. So this was a randomized trial with 429 patients with a patient's previous untreated metastatic or locally advanced non-small lung cancer, and the trial was designed from November 2018 till September 2019. So the patients were randomized 1:1 with aumolertinib 110 milligram OD versus gefitinib 250 milligram OD. The primary endpoint was to look for the progression-free survival. The secondary endpoint was to look for the overall survival, ORR, and the duration of response. The trial was powered to 90% with an HR for the PFS with a hazard ratio of 0.67. So when we see the trial design, it said that the patient had an advantage in the PFS 19.3 with aumolertinib versus just 9.9 for gefitinib with a hazard ratio of 0.46 and a significant p-value of 0.0001. Duration of response was also significantly prolonged. It was 18.3 versus 8.1 months. Median overall survival did not reach, and the treatment duration was 463 days with aumolertinib versus 254 days with gefitinib. And the most important, what I found in this trial was the side effect. The serious adverse events were just 4.2% with aumolertinib as compared to 11% with gefitinib. And see, this was the side effect profile. The PFS 19.3 versus 9.9. The median duration of response 18.1 versus 8.3. Selected AEs, if you talk about, there was an increase in alanine transferase 120 versus only 63 for aumolertinib arm. Again, SGOT 116 with gefitinib versus 64. The rashes was still less, 50% as just compared to 89% with gefitinib. Diarrhea was again less, 35 as compared to 77, though there was increase in creatinine phosphokinase. That was 76 for aumolertinib versus 20 with gefitinib. So the trial concluded that aumolertinib significantly improved the PFS and duration of response compared to gefitinib as a first-line therapy in patients with advanced non-small lung cancer with EGFR mutation. Aumolertinib demonstrated a favorable safety profile, especially regarding toxicities mediated by wild type, and these results establish it as a promising agent. But my take is that if you see the EGFR landscape that we have been talking so many frequently during our conferences and webinars, when we sequence these first line, second line, third line, you see gefitinib is always inferior to the second and the third line. We already have shown the superiority of third line as compared to the first line. So the drawback, and what I found that the comparison of this newer molecule is with the gefitinib, which itself is an inferior partner. So head-to-head trial trials have shown that second and the third generation TKIs are probably preferable agent to first generation for the first line treatment. And again, an important factor that I want to consider here is choosing the most appropriate TKI that also include the type of EGR mutation that we are having, and that should also include the uncommon mutation, which is, we are more prevalent than the previously thought of. We have just a couple of examples where we are doing an NGS and we are diagnosing this uncommon mutation, but perhaps the number must be higher than what we think of, and that can exist with the already existing mutation, which we can call it a compound mutation already existing with some uncommon mutation, where we don't have the result of this newer molecule. Though the toxicity profile, if you see, aumolertinib has an attractive toxicity profile as compared to the first line zefitinib. So we still need to explore this newer molecule. It seems attractive as concerned to the toxicity profile, but since the comparison with zefitinib is a weaker partner, and I think the comparison should have been with the second or the third generation TKI, that we could have come to a definite conclusion. So this is my take on this newer molecule. Thank you so much for the patient hearing.